Good morning, everyone. Welcome to re-examining S1p modulation from all angles in relapsing multiple sclerosis, impact on physical and cognitive outcomes, and practical considerations of long-term therapy. I'm Bruce Cree, and I'm joined by my colleague, Dr. Cree Crayton, and thanks to PeerView for providing this session. Bristol Myers Squibb is the sponsor for the educational grant. If you haven't already, please complete the pre-event survey and look for additional follow-up polling during the presentation. You have your iPads in front of you. Please make sure you registered, put your information into the iPad. That's also how you will be submitting your questions, and we will answer them during the Q&A session. Here's some information on PeerView with their website and their Twitter hashtag, I guess. All right, I'm going to let Heidi do the first part of the presentation, which is going to be examining the mechanism of action of S1p modulators in the treatment of MS and exploring their potential as first-line therapies. Dr. Crayton is the medical director of the Multiple Sclerosis Center of Greater Washington, all the way from Vienna, Virginia.
Yeah. Thank you, Bruce. So Bruce, for the first time and probably only time ever, will be at a little bit of a disadvantage compared to me because he's 3 hours behind in time. So it's nice to have this in my backyard. It's nice to see everybody so early in the morning. Thanks for being here, and thank you to PeerView. So we're here this morning to talk about S1p receptor modulators and exploring mechanism of action, where to place them, how to use them, what they're all about. When I was in medical school and in physiology and biochemistry, I don't recall really learning a lot about S1p receptors. I think we're all kind of expanding our knowledge biochemically and immunologically. But the S1p receptor system is something we've been talking about now for at least the past 10 years or so, 10 to 12 years. And S1p is a phospholipid that's released by platelets and mast cells, as well as other cells. It stimulates 5 G-protein coupled receptors that are located in endothelial cells and cardiac myocytes. And they're expressed in a variety of tissues, and that interaction is responsible for various positive effects that we're looking for, as well as some of the overlay side effects that we see with use of this class of molecule. Different receptors induce a variety of different biological responses. There are 5 S1p receptors, and each of them kind of results, that coupling results in various different responses. Proliferation, angiogenesis, migration, cytoskeletal organization, chemotaxis, trafficking, mitogenesis. So this is just kind of an overlay of all 5 of these molecules. And again, we, I think, have learned more and more over the past 12 years about some of the individual actions of these receptors and interaction with these, in a non-selective manner. We have interaction with all of these except S1p2. S1p1 is responsible for lymphocyte retention. Also, some impact on heart rate. S1p3 is responsible and has interaction and interplay with cardiac conduction. And 5 is on oligodendrocytes, plays a role with oligodendrocyte survival, migration, differentiation, remyelination. It is expressed in the CNS. So 1 and 5 become a little bit more selective in terms of output and outcomes that we're looking for with treatment of multiple sclerosis. And I always think that it's important that patients understand a little bit about the mechanism of action of the products that they're on. And this is a super easy one for a little 5-second soundbite with patients. I just say ultimately it's about putting these misbehaving cells in timeout. Most young people who have children understand that analogy. This S1p receptor is on the surface of lymphocytes that are going into secondary lymphoid organs. They're activated, they then exit lymph nodes, go out into circulation, and wreak havoc. And initially, S1p receptor modulators are agonists, but they are functionally antagonistic. They bind to S1p receptors on the lymphocytes, which results in internalization of that S1p receptor. And that S1p receptor is required on the surface in order for the lymphocyte to migrate out of the lymph node. So the result is sequestration of these lymphocytes. Just as a reminder, there's a polling question on your iPad that we'd like you to answer. So we have 4 S1p receptor modulators on the market currently. Fingolimod was the very first one, came out in 2010. It was the first oral therapy and the first S1p receptor modulator. That's when we started having this discussion about clinical aspects of S1p receptor modulation. Siponimod came out in 2019. Ozanimod entered the marketplace in 2020, and we have a new entry to the marketplace in 2021 with ponesimod. And this is looking at specificity of interaction with the various S1p receptors. And you can see that we have kind of a more broad sweeping with fingolimod, and then we have more selective with some of our newer entries into the marketplace, more selective for S1p1 and S1p5. So this is just a nice little overview of some of the functions of these subtypes of S1p receptors and the role that they play. And I think it's important, again, understanding the role that they play helps understand some of the side effect profile and some of the things we're trying to mitigate against with becoming more and more selective in our choice of interaction with S1p receptors. I think it is important to understand this because then we have an understanding of why we want to become a little bit more selective and why we don't want necessarily a broad sweeping overlay. And this is just to kind of go through some of the adverse events that have been associated with fingolimod because of this off-target kind of broad sweeping effect. In terms of cardiac, it is contraindicated for people who have had recent MI, unstable angina, stroke TIA, Mobitz type 2, second or third degree AV block, sick sinus without a pacer. Hypertension can occur mostly because of interaction with the S1p2 and S1p3 receptors. At the S1p3 receptor may be the one that's actually responsible for second degree heart block. In terms of the eyes, macular edema, we certainly are familiar with as something that needs to be watched and monitored for. And that's probably because of interaction with S1p1 and S1p2. So even with the selective S1p receptor modulators, it's something for us to be aware of. It's not something that is necessarily required to be looking at prior to initiation of therapy, but it's something for us to be aware of. In terms of pulmonary system, perhaps decrease FEV1 can occur because of S1p receptor interaction, mostly via S1p2 and S1p3. And as you saw in one of the previous slides, there's very, very little S1p2 interaction with these, with our products, but something to be aware of. Another reminder, please answer the question on your iPad. So this is kind of a comparison of their profiles in terms of half-life. Ponesimod is the most rapidly eliminated, and we have fingolimod, which takes the longest amount of time. But there's variations between all 4 of these products. In terms of time to recovery of lymphocyte counts, because we know we're going to see in Dr. Cree's presentation information about lymphocyte sequestration and ultimately having a low lymphocyte count. But the recovery time is sometimes something that we're really concerned about and we want to be able to have control over. So that's something that varies as well in terms of cessation of dosing and when we see return recovery to normal counts. And then pre-treatment assessments. I think this is everybody's pretty familiar with this. We always want our baseline labs. There's some upfront testing that is really required for use of fingolimod, and that becomes a little bit more individualized with some of the other products. Vaccination status. Keep in mind, we always ask if people have had chickenpox. If not, they should be vaccinated. And sometimes our assays, the LabCorp assay, is sometimes not very sensitive to picking up those titers after somebody has been vaccinated. So just to be mindful of that. We have genotyping that is required for siponimod. So again, requirements vary a little bit. Overall, they're pretty much the same, but a little bit different. First dose monitoring is required for use of fingolimod. We don't really have that with the others. And in terms of titration, fingolimod really mitigates the change in heart rate with that first dose observation. The others do it with a titration. So we know that S1p receptor modulators certainly have increased efficacy. There's a big step up from what we refer to as platform therapy, interferon, glutamer. And we have increased efficacy in terms of, I'm not going to steal Dr. Cree's thunder, you'll see the data, but in terms of the hoops that all of our products need to jump through to show efficacy. It's an immunomodulator. It's once a day oral dosing, which is nice for patients, especially for me, more younger and flakier patients. We have various incarnations and generations. First line, second line, third line. This is a product that from the time that it came to market, I've used as a first line drug. It's a very nice way to introduce MS to somebody who's newly diagnosed, who's young, in my opinion. It makes them feel normal to be able to take a pill like other people. So switching from an injectable product to an S1p receptor modulator certainly has been shown to have results in a reduction in lesion number. We have MRI metrics that are met. Annualized relapse rates are reduced. Lower impact of those relapses on activities of daily living, smaller reduction in brain volume, and we've been talking a lot more about that in the past decade. Significantly improved quality of life, patient-reported outcomes, and lower adverse event rate. And when I started using S1p receptor modulators and switching people over, I realized that there had been really a lot of negative symptoms, depression, fatigue, that I thought was actually part of MS, and I didn't really realize that it was overflow from use of interferons, for instance. So it wasn't so much that the quality of life changed because I was doing something. I was really kind of taking away that wet blanket effect. Another question on your iPad. So that's just a little quick, brief S1p receptor 101, and now I'll turn it back over to Dr. Cree to dive into the data.
All right. Thank you, Heidi, for that excellent introduction to the basic biology of the S1p receptor modulators. I'm going to go to review some of the clinical trial data and biomarker studies that we have. So, of course, fingolimod is the first S1p receptor modulator that came to market. The data from this product, or on this product, is based on 3 pivotal trials, 3 phase 3 studies, the Freedoms 1 and Freedoms 2 trial, which were both placebo-controlled, and the Transform study, which was a shorter duration active comparator study comparing fingolimod to once-weekly interferon beta-1a. All 3 trials met their primary endpoint, which was to show an impact on the annualized relapse rate. They all reduced the annualized relapse rate by around 50%. There was also statistically significant effects on new or enlarging T2 lesions, on GAD-enhancing lesions, And in terms of confirmed disability progression, this was shown to be statistically significant only in one of the 3 trials, the Freedoms 1 trial. Ozanimod also had 2 pivotal trials, 2 phase 3 studies, both using an active comparator of interferon beta-1a. These were quite large studies. 2 different doses of the drug were examined, but in clinical practice, we really are only using the 1 milligram dose. Both studies showed statistically significant effects in terms of the annualized relapse rate and effects on new or enlarging lesions and in GAD-enhancing lesions, but there was no real difference between the treatment with ozanimod and interferon beta-1a with respect to 3-month confirmed disability progression. These trials have gone into open-label extension studies, just as the fingolimod trials have. Ponesimod had a phase 3 study in relapsing MS. This was an active comparator study with teriflunomide and showed a reduction in terms of the annualized relapse rate relative to teriflunomide, also an impact on combined unique lesions, that's new T2 lesions or enlarging T2 lesions or GAD-enhancing lesions. And then I'll go into a little bit more detail in a moment about the effect that this drug potentially has in MS-related fatigue. Siponimod is interesting because out of these 4 products, it's the one that has been investigated in secondary progressive multiple sclerosis, whereas the other 3 have been investigated in relapsing MS. This was a large study. These patients had much more advanced MS with an EDSS score which was considerably higher, 3 to 6.5, and the median EDSS score was 6, so a very different type of patient than the ones in the other trials where the median EDSS score was about 2. And in this trial, there was a statistically significant effect. It was compared to placebo. Primary endpoint was on confirmed disability progression, and the drug hit the confirmed disability progression endpoint with a 21% reduction in 3-month CDP and a 24% reduction in 6-month CDP, as well as the expected effects in terms of relapses, GAD-enhancing lesions, and new T2 lesions. So all of these studies have led to open-label extension studies, and of course in the open-label extension there isn't a control group per se. You can compare the people who were originally on placebo or an active comparator and who made the switch, so you can certainly look at that. But of course the main goal of these open-label studies is to evaluate whether there is sustained therapeutic benefit and whether the safety profile of the products that was investigated and demonstrated in the phase 3 studies is maintained over the long term. And I'm pleased to say that with all 4 of these products, the long-term studies really have not shown any surprises with respect to safety concerns. They've all had a very consistent safety profile that goes along with the phase 3 data. And there has been a sustained benefit for all of these treatments in terms of their impact with respect to new lesion formation and the annualized relapse rate. And for all 4 drugs, the event of disability progression that's confirmed occurred infrequently. So we have another polling question for your iPad. All right, so when we think about MS, we've focused so much on in terms of relapses, on disability worsening, on focal MRI activity. And of course, these 3 measures together can be aggregated in what we look at in terms of no evidence of disease activity, or NEDA-3. And that's an interesting measure that gives us a sort of gestalt of the overall therapeutic benefit of these products. And they all have a striking effect in terms of meeting this outcome. But of course, this is just the tip of the MS iceberg, and we do know that there are many other features of MS, both clinical and radiographic and biomarker, that are not completely addressed by looking at relapses, disability progression, and focal MRI disease activity. Cognitive impairment is extremely important in multiple sclerosis, but is not adequately addressed by the EDSS, and so you have to actually look a little bit further to find an effect in terms of cognitive outcomes in MS. But cognitive impairment is a major source of MS-related disability. Fatigue is also a major source of disability, and again, is not adequately evaluated using the EDSS. So if you have an effect on fatigue, that would be, I think, an important clinical outcome. And then, of course, the brain and spinal cord are under attack, and as a consequence of MS, we all know that there is loss of brain tissue, loss of spinal cord tissue, so-called brain and spinal cord atrophy. And these processes, once we see them, reflect end organ tissue injury, which is irreversible. You cannot grow a new spinal cord. You cannot grow a new brain, at least not yet. So when you see that atrophy has occurred, that is an irreversible marker of end organ tissue injury, and this should be one of the things that we are focused on preventing, if at all possible. And then there are, of course, the lesions that we can't see by conventional imaging. More recent work using high-field magnets and, of course, histopathology has revealed a wide variety of demyelinating lesions present in the cortical gray matter and deep gray matter structures that simply cannot be visualized by standard imaging technology. And we think that these areas of cortical demyelination are critical for cognitive functioning. And I think we have to develop better and better technology to identify these areas before they have occurred and to develop treatments that influence their outcomes. And then when we're thinking about these processes, of course, there are markers that we are now in the process of developing. And I'll share some information with you on neurofilament light and GFAP, which can be measured in the serum of patients. Of course, these can be measured in the CSF, but advances in technology have allowed us to measure these neuronal biochemicals present in serum samples. And I think that is a very interesting area of ongoing research in multiple sclerosis. So now on to cognitive dysfunction in MS. Cognitive dysfunction is a very common manifestation in multiple sclerosis, and we really need to be better informed regarding the role of cognitive problems in patients with MS. We focus too much, I think, in terms of relapse prevention and disability. Worsening is measured by the EDSS. And the National MS Society in 2018 came up with a guideline recommending monitoring of function in MS by administration of neuropsychological testing to every patient at baseline, and then testing patients annually after that. Now, it's a lofty goal. I'm not so sure that this is a practical goal because neuropsych testing takes anywhere between 4 and 8 hours, and individual patients, as they come in who are newly diagnosed, might be completely normal cognitively. So I'm not quite sure we can do this. Plus, usually neuropsychologists recommend testing, repeat testing every 2 to 3 years, not annually. And the access to neuropsychologists often is quite limited. We're fortunate at UCSF to have an embedded neuropsychologist in our practice who performs all the neuropsych testing for our patients, and it can be very, very helpful to have that ancillary type of testing. So if you have a neuropsychologist available, that's fantastic. But if you don't, you have to think about perhaps there are some other ways to assess cognitive dysfunction in multiple sclerosis, things such as use of the SDMT that can be administered in routine clinical practice. It takes only about a minute to perform and can provide, I think, potentially a wealth of information about your patients, which is not adequately accessed or determined by the EDSS or other patient reports. So now only about half of the MS clinics in the country are assessing cognitive dysfunction in MS. And as I mentioned, neuropsych testing is not available everywhere, but we can screen our patients with the SDMT, and this is something, if you haven't done it yet, is actually quite easy to learn how to do, and does provide at least a rudimentary understanding about processing speed in multiple sclerosis. Now, several studies have looked at various medications and their effect on cognitive function, in particular cognitive processing speed. Those of you who've run clinical trials know about the PACEAT, which is the Paced Auditorial Serial Addition Test. It's a difficult test. Patients hate going through it. It's very challenging. But nonetheless, it does provide us insight into the ability to attend and perform some basic mathematical operations with a distractor going on at the same time. And here's data on the impact on the PASAT scores comparing fingolimod-treated patients over the first 24 months of the study, followed by those who switched from placebo to fingolimod after the 24 months and over the long term. And what you can see here is that the mean change from baseline in PASAT scores increased in those individuals who are on fingolimod the entire time. And in those individuals who were initially on placebo and switched to fingolimod, those scores also went up over time, although not quite catching up to the individuals who had been on fingolimod treatment from baseline. The EXPAND study also looked at a measure of cognitive function using the SDMT, which is the symbol digit modality test, an alternate test that is not as draining as the PASAT is, and anxiety-provoking. And here you can see the Kaplan-Meier curves for confirmed cognitive worsening, comparing the group, which is in blue and continuous siponimod, to those who were initially treated with placebo and then switched over to siponimod. Now, this particular trial had a variable duration of time on placebo. Individuals who, after 12 months of treatment, met confirmed disability worsening at 6 months were allowed to roll over into active treatment, and so there was a variable amount of placebo exposure, anywhere between 12 and 36 months, with the median time on placebo of about 18 months. And as you can see here, those who switched over from placebo to siponimod had a different Kaplan-Meier curve compared to those on continuous siponimod, indicating that treatment with continuous siponimod was superior to placebo over the long term in terms of delaying the time to 6-month confirmed cognitive worsening and time to reach the 25th percentile. That's a 60% difference. Now, fatigue is common in multiple sclerosis. We don't have good ways of measuring it, but it is a major cause of disability. And between ambulatory impairment, cognitive dysfunction, and fatigue, these are the three main drivers of loss of vocation in multiple sclerosis. Fatigue, of course, is an invisible symptom. It can manifest in many different ways. It can manifest as neuromuscular fatigue. It can be almost indistinguishable from depression. It can be brought on by sleep disorders. It can be a profound lassitude, just a general lack of energy. And it has got a tremendous burden in terms of reducing activity, productivity, and has a massive economic burden for patients living with MS. So claims analysis of over 4,000 patients treated with DMTs for over 5 years showed that up to 46% had fatigue documented by ICD-9 and ICD-10 codes, sleep studies, and stimulant prescriptions. And so we keep giving patients who have fatigue stimulants, and I think that's okay for the type of fatigue that manifests as excessive daytime somnolence, but a stimulant like Adderall or methylphenidate or modafinil is simply not going to do anything for a patient who has no energy. You're just going to keep them awake without energy. You're not giving them the energy back. And of course, patients who have fatigue are more likely to have comorbid depression, anxiety, cardiovascular disease, and GI disorders. So I think we really have to do a better job of characterizing fatigue and doing something about it therapeutically. So here's data from the ponesimod clinical trial, which compared itself to teriflunomide. And you can see here a symptom domain of fatigue using the Fatigue, Symptom, and Impact Questionnaire for Relapsing MS. Now, this is a novel questionnaire that had been developed really for this clinical trial and shows you the change in fatigue scores from baseline all the way through to week 108. And a decrease in score is considered beneficial, an increase in score is doing worse, and you can see that by week 108, the ponesimod treatment group had no change in baseline fatigue, whereas those on teriflunomide experienced worsening fatigue, and this was statistically significant at week 108. So it is possible that ponesimod has a beneficial therapeutic effect on fatigue, although this information comes from the clinical trial. It did not make it into the prescribing information for this particular product. Now, what about brain volumetrics and end organ tissue injury? Well, all of these clinical trials have used advanced quantitative imaging to look at brain volume, to look at deep gray matter volume, thalamic volumes, and cortical volume. And here's data from fingolimod looking at this, pooled data from the phase 3 clinical trial program. And what you can see here is a significant effect of fingolimod on overall brain volume loss, on deep gray matter volume loss, and thalamic volume loss. The last box here of cortical gray matter showed no difference, but nonetheless, you get the idea that there is an impact of fingolimod on preserving overall brain volume and gray matter structures over time, and I think this is very important. When you look at overall brain volume, the degree of brain volume loss on fingolimod is normalized to the lower limit of normal for those individuals who do not have MS. And I think this is an important message, telling us that you can preserve brain tissue by treatment with S1p receptor modulation. Ozanimod showed similar effects. Here you can see an impact on the brain volume change at 12 and 24 months for its 2 pivotal trials, first on whole brain, then cortical gray matter and thalamic volume. And you can see that there's an effect of both doses of ozanimod, but only the 1 milligram dose is used in clinical practice. And all of these changes were compared to the active comparator, interferon beta-1a, once weekly. And now, in terms of ponesimod compared to teriflunomide, there was also an effect on overall brain volume loss that reached statistical significance by week 108. And then for siponimod, there was an effect in reducing both cortical gray matter and thalamic volume loss, and this was shown in the overall treatment population, and sub-analyses were also performed in those with active MS, meaning those individuals who came into the study and had a relapse in the 2 years prior, or a GAD-enhancing lesion at baseline, and these effects were seen in the active MS subgroup as well. So now, what about biomarkers? Well, neurofilament light is a biomarker that has received a lot of interest in MS. The new Simoa assays are highly sensitive and are capable of picking up neurofilament light concentrations at the picogram amount from serum samples. And serum neurofilament light was looked at as a biomarker in the fingolimod clinical trials. First, in box A at the top is the FREEDOMS studies, and you can see that these are, of course, the placebo-controlled trials, and you can see the decline in serum neurofilament light with active treatment in the red bar or red line compared to the blue line of placebo, and a reduction in serum neurofilament light is implied to mean a reduction in neuronal injury, because serum neurofilament light is released from neurons. It's present in the axons of neurons, and as a consequence of tissue injury, it's released, it winds up in the blood, and so a reduction in serum neurofilament light is considered to be a good thing and a marker of decreased ongoing tissue injury. And in the panel below, you can see a comparison here of fingolimod to interferon beta-1a, and once again, you see normalization of serum neurofilament light back to the healthy control level with fingolimod treatment relative to treatment with interferon beta-1a. Now, what about serum Gfap? Well, serum Gfap is a marker for astroglial injury. Gfap is present in astroglial cells, and in the ozanimod clinical trials, 2 different doses of ozanimod were compared to interferon beta-1a, and you can see that in red, the interferon beta-1a data clusters together, and the ozanimod data clusters together at both the 0.5 and 1 milligram dose. On the y-axis is the impact in terms of the adjusted annualized relapse rate on top, and on the x-axis is the concentration of serum Gfap. And so what your eye can see immediately is that treatment with ozanimod not only reduces the annualized relapse rate, but also reduces serum Gfap, and this can cleanly distinguish that group treated with ozanimod versus the group on interferon beta-1a. We see similar effects in the next box in terms of contrast-enhancing lesions and new or enlarging T2 lesions, and there is hope that this biomarker can give us an insight into ongoing MS disease activity without the need for frequent imaging. So it is possible, conceivable, that we could use these biomarkers as proxies for tissue injury, potentially allowing us to perform serial assessments, perhaps, for example, in a phase 2 type of study where we want to get a sense of the rapidity of impact of a particular treatment and whether it can be measured by serial blood samples, say once a month or once every other month over a course of a 6 month or 1 year period. And that might be something that could be useful since it's impractical to do monthly MRI scans in the same patients. Just an idea about how these things could be used. Now, when we try to put all of this together, one of the interesting studies that I just want to show you, now this is a very complicated slide, but I'm going to walk you very briefly through it. What this slide does is it takes a supervised machine learning approach, integrating information about serum neurofilament light and brain volumetrics, looking at lateral ventricular volume, gray matter volume, and then ask the question, if we can integrate these things, can we develop a model for prediction of cognitive worsening in terms of SDMT scores? And the short answer is yes. So when you integrate measures of brain volumetrics with serum biomarkers of chronic tissue injury and ongoing tissue injury, you can come up with a model that is predictive for who's going to be at highest risk of cognitive worsening. So I think this is going to be the start of a new era of investigation in MS, where we really are taking the knowledge that we have about brain volumetrics, serum fluid biomarkers, and applying them to our understanding of long-term cognitive and other outcomes in multiple sclerosis. So we have another question for you to answer on your iPad. And now I'm going to take a break from the podium and go sit down here with Heidi, and we're going to now begin our practicum case discussion, bringing it into focus, individualizing management of relapsing MS to achieve optimized patient care. So our patient is a 28-year-old right-handed Latin American woman who has a history of depression that's treated effectively with citalopram. She presents with a left occipital parietal headache. It's associated with pins and needles paresthesias on the scalp in the same distribution. The headache is pulsatile, associated with nausea and photophobia, but is without aura and no phonophobia. She's diagnosed with migraine, and she started on amitriptyline, riboflavin, and sumatriptan. The patient notes that amitriptyline is ineffective at preventing the migraines from occurring, but sumatriptan or sleep can abort her headaches. She also describes muscle twitching around her left eye. She has intermittent tingling paresthesias in her feet, and she's had urinary urgency, which is new for her, for the last month. And on exam, she's got orbicularis oculi myokymia. She's got diminished vibratory sensation in her toes. And her EDSS score is 2, with the following functional scale scores. Sensory is 1, brainstem 2 for the ocular myokymia that the patient's aware of and is bothersome to her, and her bowel and bladder score is 1. So she ultimately undergoes a brain MRI, which shows multiple ovoid T2 hyperintensities throughout the supratentorial white matter, some of which are periventricular. She's got a left cerebellar peduncular lesion as well. And there are 3 contrast-enhancing lesions on the scan, one of which is ring-enhancing. Cervical MRI is normal, but her thoracic MRI discloses an area of abnormal signal change from T3 to T6, which is ill-defined. So she's got a longitudinally extensive T2 lesion in the thoracic cord. She goes on to have CSF, and in the CSF, she's got 6 white blood cells, normal protein and glucose. The IgG index is elevated at 1.4, and she's got multiple oligoclonal bands present in the spinal fluid that are not present in a corresponding serum sample. Additional laboratory tests show a positive ANA with the 1 to 40 pattern. Her vitamin D is low at 14. JCV is seropositive with an index of 1.6, and all of the other studies are either negative or normal. And so she's diagnosed with MS, migraine without aura, which is not intractable and without status migrainosus, and vitamin D deficiency. Now, I practice in San Francisco, and our catchment area is quite broad. We serve a very large area of Northern California all the way up to the border of Oregon in Crescent City, which is about 9 hours away from San Francisco. And this patient lived in a remote rural area, and her nearest infusion center is about a 5-hour drive away. She's also needle phobic. So with all this information, Heidi, what do you think we should do in terms of treatment? I put up here, I think I got pretty much all of the MS therapies on here that we typically would think about. What would you do therapeutically for this patient? What are your considerations?
Given the fact that she's Hispanic, we have data that shows that we have ethnic differences in autoimmune disease and MS presentation. So initially, in my mind, that kind of puts her in a category of somebody to be a little bit more concerned about. The fact that she has brainstem and spinal cord involvement is certainly going to shorten her path to disability. So she needs high efficacy therapy. It's very unfortunate that she lives so far from an infusion center, because an infused monoclonal antibody would certainly be my go-to for her to get her to a better baseline and protect her CNS. Given that she is so far away, and that's really not an option, I probably actually would offer her an S1p receptor modulator.
Yeah, so I think the interferons in GA, of course, are self-injected, and the patient's already told us she's needle phobic, so probably...
And less effective than what she needs.
And probably less effective, too. And she's 28, right? So a woman of childbearing age, I typically are not going to... I, in my personal practice, just my opinion, I'm not going to reach for teriflunomide in those patients.
Me neither,
right? Yeah. Certainly, I think a fumarate could be considered, right?
If she's reliable.
If she's reliable, exactly. So you have to be willing to take a medication twice a day, or even 2 pills twice a day, right?
Right.
So S1p modulators, I think, as you said, make a lot of sense. She's JCV seropositive. That always gives me pause before recommending natalizumab, although we can do extended interval dosing now. And and that reduces the risk of development of PML. I think an anti-CD20 is reasonable. What do you think about alemtuzumab? Is this a patient that you would start an alemtuzumab?
I think that certainly should be part of the conversation, with the exception that she is so far away from lab services that I think the burden of monthly blood work for 5 years would be incredibly burdensome. So I don't think it's realistic.
Yeah. I think there are quite a few challenges with use of alemtuzumab in this particular case that would make it difficult. What about cladribine? What do you think about cladribine? I mean, it's got the convenience of an oral therapy. You have a few pills for a few days in a row. You're good for a year. You do it again, and that's that.
Personally, I wouldn't, as first-line therapy for this acutely inflammatory patient. The fact that she's younger and of childbearing potential, that's actually where I do discuss cladribine with patients to be able to have finite treatment and have that treatment done, and then they can proceed with family planning. But in this particular patient, if I had my druthers, I would helicopter into an infusion center.
All right. What about mitoxantrone? What are your thoughts about that? Do you still use mitoxantrone?
I haven't used mitoxantrone in quite a while, and I think
Still available, though.
it's still available. I think its use and utilization is pretty rare in the U.S., and we've certainly seen the downslide of choosing mitoxantrone with cardiac toxicity, and so that's
So
not an
myelocytic
option.
leukemia, hard to go ahead and
Yes.
throw that at a 28-year-old.
And infertility.
And infertility.
For a young
hard,
woman.
hard to do that to
Yes.
a 28-year-old
Yes.
patient. All right. So the patient, so you're here at an S1p receptor modulator meeting. Guess what? Patient starts an S1p receptor modulator, right? Okay. What's the real world data on first line S1p treatment? Well, generally speaking, when we look at patients who are started on highly effective frontline therapies, so-called HEFT therapies, they tend to do better than our lower therapeutic efficacy treatments or light therapies. They tend to do better over the long term. And so we have data from multiple sources of observational cohorts showing that high efficacy frontline treatment is better in terms of long-term disability than our tried and true therapeutic escalation approach. Now, I think this is being used a lot in clinical practice, but it hasn't come completely all the way into focus because we don't have yet randomized controlled trials. I think we eventually will, right? We have 2 trials which are ongoing right now that are going to address this type of therapeutic paradigm approach, and we'll have data coming out in the years to come from those randomized controlled trials. But a lot of us who see many MS patients are already making the switch and going away from a fix-on-fail approach and using the higher efficacy therapies, which in my opinion include the S1p receptor modulators, but certainly the monoclonal antibodies as well as frontline. And this is really, I think, being predicated by first natalizumab in JCV seronegative patients and the ability to monitor for JCV seropositive conversion, and then with the anti-CD20s as well, where the adverse event profile is generally quite favorable.
Can I just add to that this data is even more robust for Hispanic, African American population, non-white population of patients, and I think especially our non-white males that tend to have so much more impending disability if not attacked very aggressively early on. I think that's really important for us to remember, that we really cannot approach that group of patients with an escalation stepwise approach.
That's right. Yeah, well, you're
doomed to failure.
Yeah, exactly. You're generating therapeutic success based on failure. So, all right. So let's continue with our case. So you know, just in general, I would say all DMTs are effective in treating relapsing MS. Some are more effective than others. And of course, when you're selecting a DMT, you should consider comorbidities, concomitant medications, patient-specific factors that may influence treatment adherence. So our patient starts an S1p receptor modulator. Her orbicularis oculi myokymia resolves. She's got ongoing urinary urgency frequency and develops nocturia. Her PVR is only 10 cc's. She's tried and fails on oxybutynin, telteridine before finally getting on mirabegron, and then has improvement. Her migraines are managed by a combination of verapamil, magnesium, riboflavin, sumatriptan. Still has about 6 migraines a month, but I can't get a CGRP for her due to insurance reasons. And then the COVID-19 pandemic started. So what about COVID-19, MS, and S1p receptor modulators? Does MS confer greater vulnerability, poorer outcomes with COVID-19? Does use of DMT affect vulnerability to COVID-19? And how do DMTs in general affect vaccine efficacy? And in particular, does S1p receptor modulator affect COVID-19 vaccine responses? So if you are an obese man with diabetes and cardiovascular comorbidity and pulmonary problems and hypertension, and progressive MS, and you get COVID, you're probably not going to do so well, right? These are the major risk factors, and I think we are all familiar with this. The higher the EDSS score, the worse the clinical outcomes. If you've been treated with corticosteroids recently, you tend to do worse as well. And interestingly, there may be an effect of CD20 monoclonal antibodies in terms of making outcomes a bit worse compared to dimethyl fumarate. But no treatment is worse than treatment, so perhaps these things do wash out a little bit. Fingolimod reduces the immune response to vaccination. Vaccination can be less effective for about 2 months after discontinuation of fingolimod, and of course one's not supposed to use live or attenuated vaccine during treatment. There can be reductions in terms of vaccine efficacy, looking at keyhole limpet, DTH, and influenza, and other S1p receptor agonists also have effects in terms of SARS-CoV-2 antibody. You can see here on the lower graph the effect of pre and post-vaccination of the various therapeutics, the pre-vaccination in the blue dots, post-vaccination in the black dots, and you can see for just about everything, there's a rise in the presence of CD4 positive cells, but this response is quite attenuated with S1p receptor modulators in general. And we see an impact in humoral immunity too, with reductions in antibody responses as measured by the semi-quantitative SARS-CoV-2 antibody test. So this patient gets vaccinated 3 times. She actually got the Pfizer vaccine, although that's not all that relevant. However, despite vaccination, she contracts COVID. She's admitted to her local hospital. She gets oxygen. At that time, Paxlovid wasn't available, but it's something I think most of us would give the patient right away at this point. She does recover, but has some lingering dyspnea with exertion, and we check her for SARS-CoV-2 antibodies, and she has no detectable antibodies by the index. Index value is less than 1. So we stop her S1p receptor modulator, and after 2 months, we wait for her absolute lymphocyte count to recover, and it comes back from 0.4 to 1, which is back into the normal range. And we revaccinate her, give her 2 more doses, this time with the Moderna. And then her SARS-CoV-2 antibody 2 weeks after that second dose is now greater than 2,500. Brain MRI is performed for safety, shows no new or active lesions. There is concern about a hypothetical rebound that might occur following S1p receptor discontinuation. And so she was monitored carefully for any signs of MS disease activity, and her MRI was stable, and her S1p receptor modulator was restarted, and now she's doing okay. So these are some details from this case. I don't know, what's your experience, Heidi? Have you been taking patients off of treatment and then revaccinating and putting them back on, or do you just keep vaccinating with the hope that one day they're going to seroconvert? Do you use in your own practice the SARS-CoV-2 antibody to assess for your MS patients on various DMTs?
You know, I actually do. When the pandemic started, we really didn't have any information, so I figured I should probably start gathering information to help guide me. So for the past 18 months or so, we've been collecting on every patient, every visit. I have a big spreadsheet of antibody status by drug. So I've collected quite a bit of data, and that really led me to, help kind of guide people through and navigate through the pandemic and vaccine. So initially, I was actually manipulating their S1p receptor product, holding it so that they could actually have a response. That actually created a lot of anxiety for patients to be off of their S1p receptor product. So I stopped doing that, and actually just across the board now, for the past 6 months or so, I've just been giving all of my anti-CD20 patients and my S1p patients EvaShield, and just saying no more boosters, no more vaccine, let's not waste the time, I'll just provide you with the antibodies. So that's how I've been managing those patients. It's just kind of been a learning process, I think, for all of us throughout this time of pandemic.
Yeah, we're using a lot of Evusheld too, and we'll see. You know, right now, I've had patients get COVID despite treatment with Evusheld. Right, like they just got Evusheld and then they get COVID, and that's not supposed to happen. And I think it's teaching us that this virus is going to continue to change. It's going to continue to mutate. And it is going to avoid even our most advanced monoclonal antibodies that we currently have.
I think it does give us some protection against Omicron, which at the time was the big concern, and now you're right with constant evolution of this virus. But I think that people have less severe cases or asymptomatic oftentimes.
All right. So we have another polling question for you on your iPad. So just in summary, consider early initiation of S1p receptor modulators as frontline therapy or any really highly effective frontline treatment. Think about cognitive function in your patients and consider use of cognitive assessments such as the SDMT, which can be used for monitoring your patients in your practice. And consider the impact on cognitive outcomes when you're selecting your DMTs for your patients. Not all DMTs have shown effect on cognitive preservation. We've got another question for you on the iPad, and then we're going to begin, I think, the Q&A session, right? All right. So we have a question from the audience, and I'm going to take my glasses off so I can read it. Since the blood-brain barrier neurons in all glial cells have various combinations of all the S1p receptors, is it not theoretically possible that an S1p agent that covers more of the S1p receptors may have some beneficial short and long-term effects on inflammatory and degenerative MS? So I guess the idea here is that maybe fingolimod, which hits S1P1, S1P3, S1P4, S1P5, would have an advantage over ozanimod and siponimod and ponesimod, whereas ozanimod and siponimod would have an advantage over ponesimod because they hit S1P1 and S1P5, whereas ponesimod's S1P1 specific. So what do you think, Heidi? This is a perfect question for you. Do you think that hitting them all is better than hitting some?
I don't. I think that S1P5 is one of our probably more highly focused in the group. And I think that we really do have to try to balance side effect profile. And that broad sweep we've seen really gives us an increased incidence of side effects that we have to manage. So I think over time we've seen that for ourselves with experience.
Yeah, no, for sure. I think the development of the more selective S1p receptor modulators, although they have not been compared in a head-to-head randomized controlled trial against fingolimod, has clearly shown, nonetheless, cross-trial comparison caveats all in place, that they have a cleaner side effect profile, and they still have excellent evidence of therapeutic benefit. Yeah. So, if you look at the impact on the annualized relapse rate, comparing siponimod, for example, to fingolimod, they're both reducing the annualized relapse rate by about 50%. Yeah. So to me, that seems very consistent with the overall therapeutic beneficial effect. That seems, entirely consistent for this class of therapy, but with an improved side effect profile. I think that's really important. Yeah, the data, I think, there is really apparent. Here's another question in terms of consideration between selection of a frontline therapy. How would you choose between an S1p receptor modulator versus an anti-CD20?
Or others.
Or others. Yeah.
Really, for me, ethnicity plays a very large role. Gender plays a large role. And degree of inflammation. And if I feel like I'm in a position to be able to really preserve CNS tissue in those people that are a little bit more highly active. So I get a little bit more aggressive with those people that I'm a little bit more concerned about risk. Up front, my personal disclaimer is that I don't prescribe self-injected interferons or Copaxone anymore. In my practice, I really turn to orals or infusible monoclonal antibodies. And it's really, then orals we kind of pare down in terms of what's appropriate for their lifestyle and family planning. And but I don't hesitate at all with people that are at high risk I really do push them towards monoclonal antibody. I have quite a few of those people that I actually push very aggressively towards natalizumab. Those people that I'm very concerned about. So even just to be able to kind of quiet them down and stabilize them and then switch them to an oral therapy.
All right, we have time for one last question, and this is going to be a really hard one. What do you do in older patients who have steadily progressive disease? And I think by that means without much
Smoldering.
smoldering
The word smoldering.
MS without the inflammatory disease activity. What's your choice for those individuals?
I kind of juggle balls around and I tell them to pick. Everything that we use doesn't do enough.
No.
And we still have those people. What I do tend to focus on, though, is really, really optimizing symptom management, improving speed, nerve conduction, try to optimize bladder, bowel, fatigue, try to get them moving. Spasticity is really a big one that can make a great impact on improving EDSS. So I tend to focus more on that and have them on something, just sometimes teriflunomide, just as kind of an insurance policy. Maybe it just helps me sleep better.
Yeah, I use anti-CD20, in particular ocrelizumab in this setting, and of course siponimod. Limited data indicating some degree of efficacy for both of those products in these individuals, but we only have data up to the age of 55 for ocrelizumab. So
somehow is actually referred to as older in clinical trials. I don't quite understand.
Well, I was thinking of it, like a 65-year-old patient.
Oh, at least.
Right.
At least.
Who's gradually worsening. So, yeah. So there you have it. We have a big unmet need for non-relapsing progressive forms of multiple sclerosis, and hopefully some of the work that's currently being done with Bruton's tyrosine kinase inhibitors, or perhaps even EBV-directed cellular therapies will provide us the breakthrough that we need for that form of MS. So thank you all for joining us this morning. Early morning, for especially those of you who've come from the left coast, and then regular hours for everyone else. Pleasure working with you, Heidi. Thanks to peer review, and have a great rest of the meeting.
Now you can